did well during your cardiac test. I did very well. I generally monitor that all the tests in my office, and it's very refreshing and happy. Any questions about what we talked about last week? Okay. Go back for a second. So, just briefly, we talked about metatarsals adductors, right? Adductors, right? Talk about what you need to look for, the deviation of the bones, right? The metatarsals medially. Talked about looking at the foot, just from a physical exam perspective, right? Direct observation, and you will do that with every exam that you do of the lower extremity, right? Not just the foot. If you see a foot like this, you can tell that there is something going on there, right? So you have to understand what's normal, and then you can determine when something does not look as normal as it should. I did ask you guys to pay attention to this chart because it is a good representation of how you can tell the degree and the grading for a patient with metatarsals adductors. Remember that as that first metatarsal deviates medially, sometimes it takes that entire ray with it, right? We talk about the ray being the phalanges as well as the metatarsal. So you can see the splaying of that great toe, right? That does not look normal. And then we talk about, in cases where a patient needs direct follow-up, then you can simply ask parents to take repeated photocopies of the baby's foot as a low-cost option. Okay. There may be some parents who may have reservations about doing that. So just be on the lookout for that as well. We talked about OCDs of the talus, right? And we did mention that these OCDs are more common on the medial aspect, the superior medial aspect of the talus. Now, I think throughout the course, right, and I'm a little old school, I'm kind of working on it, I kept referring to these things as OCDs, right? The new term has changed, and I think one of the students brought this up. Why does it say osteochondral lesions and you keep saying OCD? Right? Okay, so it's osteochondral lesions. Lesions in the sense that there's not always a defect there, so it kind of changes the term. Okay? So you see it in your clinic, right? So you see it on your exam. Don't pitch a fit about it because you see osteochondral lesions and I kept saying OCDs. It's the same thing. Okay? So you'll have no excuses from the testing. Okay, and it is on the medial aspect of the superior talus, right? And the reason for that is I told you that the talus is one of the most significant weight-bearing bones in the body, and so when you have these repeated stress patterns, then it sort of denudes the cartilage. You peel microtrauma to the cartilage, eventually it breaks off into something that kind of looks like what you see in that top left photograph, right? Separates from the underlying bone, and now you've got a loose fragment in the joint. Okay. Loose fragments in any joint is not acceptable, right? It's bad for a joint, but things to move around and affect the rest of the cartilage. MRI, not the CT scan, okay, is a study of choice for assessing the degree and the extent of osteochondral lesions. So again, the MRI is a study of choice for assessing the degree and the extent of osteochondral lesions. Okay. As you can see in those two radiographs at the bottom, you can tell, right, the one more to the left with the positive arrow sign, there's a little black spot there that does not look like the rest of the bone, right? That is not normal. The rest of the bone appears to be normal, right? That dark spot is not normal. And here's another graphic representation. Again, I think that's where we broke after the last class. Is that correct? All right. Davos is shaking his head, so that must be true. Okay, let's talk about tarsal correlation. And a correlation is really just an abnormal, right? It's an abnormal connection between two of the tarsal bones. Now, there's an age distribution to this. This connection can happen between the calcaneus and the navicular. It can also happen between the talus and the calcaneus. Most times you have one and only one. Doesn't mean that you can't have more than one correlation, right, between the calcaneus and the navicular, or the calcaneus and the talus. You guys tracking? Okay. In most cases, you have only one, it's only on one side, but you can also have it on both sides, right? And so, as I tell you, if you find an abnormality on one part of the body, it is always wise to check the contralateral side. Sometimes you can request a history of course, the family member lineage. Now, give your attention up to that picture on the right side. So when there is a calcaneo-navicular correlation, right, between the calcaneus, a talocalcanean correlation between the talus and the calcaneus, what level of motion do you expect to be affected? Before you answer, I want you to think of what happened at that joint between the talus and the calcaneus. You can't mess with the arch. So then the patients would present with pes planus, right? It's one. Okay. What about motion about that joint?
Inversion of the foot.
Where does inversion of the foot occur? No answer is wrong. Just want to think through the process, right? And don't cheat. I think I took it up on the slides. So if you're looking ahead, trying to figure it out, right? But think about it, right? Inversion and eversion of the foot, right? We're talking lateral and medial action, right? Yes? Where in the ankle joint does that motion occur? And then somebody say, between what? Remember, you have to go back to anatomy. All right. So, remember in the very earlier on, right? We talked about that tibio-talar joint, right? Yeah, you just didn't want to say that. I kept hearing whispers over there, right? And the tibio-talar joint is where you've got lateral and medial action of the ankle, right? And I told you that the joint forms a little saddle and allows the talus to rotate underneath the tibia, right? But it's bordered by the medial malleolus and the lateral malleolus on either side, right? There's not a whole lot of motion at the joint between the talus and the calcaneus, right? Not a whole lot. There is some, not a whole lot. And I ask the question because it's very frequently that even during one of our other previous classes, that folks were thinking that that action, that medial and lateral motion, occurred between talus and the calcaneus. It's not, right? Inversion, eversion occurs at the tibio-talar joint. Yes? Okay, make that mistake. So, we talk about the age distribution between calcaneonavicular and talocalcaneal coalitions. Generally speaking, talocalcaneal coalition occurs at 13 to 16 years of age. So, your younger patients are going to present with calcaneonavicular coalitions, right? If a patient presents at about 9 years old with a calcaneonavicular coalition, is it likely that you're going to see him? When you answer, listen to the question. Is it likely that you're going to see him when he's 15 with a talocalcaneal coalition? If you say yes, raise your hand. Okay? If you say no, raise your hand. For those of you that say no, why not? Exactly. Because I just told you that more than one is rare, right? Yes? And what was my question? No, when I repeated the question, right? What was the question that I asked? Is it likely? So let me pause for a second. Let me get your attention. Okay? I generally try not to teach you to take an exam, right? But you have to pass phase 1 so you can go on to other things, right? You have to read the questions. You absolutely have to read the test question. You will never get a test question that's going to say, identify, you know, the calcaneus in this photograph. You got to pass that. Right? You'll pass that arithmetics, and you definitely, once you got out of freshman class, that's anatomy, right? Now you got to start putting these things together. So questions like, you know, the most common. You'll see there may be more than one treatment option for anything. Just like when in your practice, there will be more than one treatment option, right? But the question is, what is the most right of all your treatment options? Okay? Is tracking? All right. Pay attention. Now, sometimes these patients may present with insidious pain, right? And it doesn't happen until they get late into their teens or into their preteens, because now they're starting to get into other activity, right? They're starting to jump, they're starting to run, just like we talked about some of the other conditions. And so now they're starting to have some more symptoms. They may present with more frequent ankle sprains. Why? Why is it that a patient that has a coalition may present with increased ankle sprains? Less flexibility, less movement, and therefore, okay, it's pretty scientific, right? So because they have less flexibility about the joint, and normally your foot will compensate, right, on uneven terrain to ensure that you maintain your center of gravity. And so because you've taken away that compensatory mechanism, you put increased stress on the ligaments, and therefore you have more ankle sprains, right? Very simple. And we mentioned earlier that patients with coalition may present with pes planus. In those cases, because you have decreased hindfoot motion, we talked about the bones that form the medial longitudinal arch, right? And therefore, you got increased flat feet, and in those cases, that pes planus is a little rigid. So younger patients, then you might have a flexible flat foot. In the case of a coalition, you got a rigid flat foot. Okay? Now we talked about the tibial-talar joint being the main action for inversion and eversion of the foot, right? I told you that the motion about the hind foot is not a whole lot, right? But there is some motion about the hind foot, right? And when we get into looking at some of the other conditions with equinus of the hind foot, you will see why some of this may have to occur. We pause for a second and revisit something that we talked about. We did a lot of discussion on the medial longitudinal arch, right? Are there any other arches in the foot? What are they? I mean, you should know what's going to answer the question. If there's a medial longitudinal arch, then maybe there is a lateral longitudinal arch, right? There you go. Right? And so there are actually 4 arches in the foot. The other 2 we'll cover when we start talking Lisfranc and the Chopin stroke. Right? Remember that diabetic foot that I talked about? That collapse of the midfoot? Okay, that's also one of the arches in the foot. We'll get to that in a minute. Just remember, just for your own education, that there are 4 arches in the foot. Okay. So when these patients present decreased range of motion, potentially they have some pes planus going on, right? Your physical exam should be the same as any other physical exam that we've done here in this class, right? You want to watch the patients walk. You want to take a look, right? Observe the foot. Palpate the bony prominences, and tomorrow we'll get into some of that during the lab. You guys are tracking me out a lab tomorrow, right? Okay, tomorrow afternoon. Okay. So you do your inspection, you do your palpation of the bony prominences, try to feel for those underlying structures beneath the soft tissue. Okay. Then you go into your special test. By then, you should have a good idea as to what your diagnosis should be, or at least have a working a list of differential diagnoses, right? That should probably steer you in the direction of whether or not you should get some radiographic studies. Okay. And if you remember, I told you that maybe 60 to 70% of your diagnosis is going to come from patient history and physical exams. If you rely on your x-rays to make your diagnosis, you are already behind. If you want to take a look at, so first you want to make sure you get what sort of views of the foot. What sort of x-rays do you always order for the foot? Weight-bearing x-rays, right? And now you get a special view called the Harris view that allows you to see the heel. And that allows you to get a better idea for talocalcaneal coalitions. And even when after you get the x-ray, it may not be as evident, right? And so you may have to get additional studies. Now, in this case, the CT scan is a little more helpful than an MRI. Now, I just told you 2 minutes ago, if you want to get a better appreciation for the extent of an OCD lesion, right, or osteochondral lesion of the talus, you get which film or which study? MRI, right? Now I'm telling you that if your x-ray is inconclusive, right? If your x-ray is inconclusive for a talocalcaneal coalition, then you get a CT scan. Okay? It doesn't mean that you cannot get an MRI in either one of those cases. One study is just better than the other. Right? Any questions on this? So how do you treat these? If they are asymptomatic, right? If they are asymptomatic, direct observation and activity modification is the way to go. So, patient comes in, they may have mild to moderate pain, but it's tolerable. Soft tissue rest, activity modification, some NSAIDs, and have them report for follow-up. Okay. There are cases where they may present with severe symptoms, i.e. severe pain, severe range of motion limitations, and in that case, the decision can be made to put them in a short-leg walking cast for 4 to 6 weeks. When non-operative management fails, then what do?
Operate.
You don't operate. You refer them for specialty care, right? Refer them to Ortho. In that case, then Ortho does one of these procedures that you see here, right? You can either resect the coalition, separate the bones, put some fat in between, right? In a position fat between the two bones just to help and prevent them from fusing again. I do not recall what the recurrence rate is after that procedure. That's something that you should be overly concerned about, but it does happen. When all else fails, or if interposition fat procedure fails, then of course you can always do an apheresis, which is fusing the helps prevent pain with the weight area. Okay. Toe walking. Okay. When kids, pediatric patients, they may present to you, or mom may present the kid because they're concerned that the kid continues to walk on their toes. Okay. For a toddler who is just beginning to walk, is this normal or abnormal? It is normal, right? And there are some kids who just, out of habit, they prefer to walk on their toes because they can reach up and grab the hooks of the table, right? And some kids, there are those that just like it just because it's a fun thing to do. Okay? Now, when a kid begins to walk and has been walking normally, right, flat-footed, and then begin to walk on their toes, and refuses to put their feet down, right, then you should be a little more concerned. Okay? So, for kids that are just beginning to walk, toe walking is normal. Kids that have been walking and then begin toe walking, it's a little abnormal. Okay? Especially if the kid's been doing it for a while and you start seeing calluses, right? Or something similar, thickened skin at the bottom of the forefoot. That definitely is not normal. There are several conditions that actually can lend to this. We're going to get to that in 2 seconds. So, you may have to refer these patients, okay, because the parent is concerned. This is one of those cases where I got to tell you, you have to listen to the parents and their concerns, right? Because the parents know the kids better than you do. They see them all day, every day. You're just seeing them for 5 minutes, right? And some parents will be hard pressed about you trying to tell them about their child and they've been living with for the last few months. Okay? So listen to the parents, and in cases where you have to refer to pediatric orthopedics, then by all means. Okay? We talked about discomfort in the forefoot. Now, there's some things that are going on in the hind foot, and that may be because of other conditions that are going on. Okay? In the case of instances where the kids have a painful calcaneus or painful calf or painful Achilles, then that certainly is a reason for alarm. Okay? There are certain muscular and neurological conditions that can cause kids to continue to toe walking. Okay? Things like muscular dystrophy, right? Or any of the neurologic conditions that tend to affect muscles and nerves. To include cerebral palsy and folks on the autism spectrum. One thing that you do have to do, right, during your assessment is to make sure that you check for a tight heel form, right, or contracture of the calf muscles. It should be all part of the physical exam. I'd like you to just make it standard practice. You know, when you're assessing the foot and ankle, remember I told you the muscles that move the foot, they are all where? In the legs, right? Yes, you guys remember this? Day one? All right. So everything that moves the foot, right? All the tendons, they all cross the ankle joint, but the muscles all live up in the legs, except the interosseous muscles of the foot normally, right? Okay. So make sure you check those as well. So how do you treat these? Well, if it's normal, right, especially for a kid who's just beginning to walk, then it's absolutely appropriate for you to just continue to observe. Right? These things tend to resolve in a few months. You can actually ask the parents to do some stretching exercises at home and encourage the child to walk normally. In cases where there is probably severe contracture, then of course we can put them in the cast. There may be instances where Achilles tendon lengthening procedures are, but those are severe cases, right? And you would tell because by then you'll have tried all your non-operative management, none of it works, and then you refer them for these longer-term procedures. What are some of the red flags? Well, number one, if your non-operative management is not working, that's an indication for referral, right? If you notice that the kid is only toe walking on one leg, that may be an indication that will raise some red flags for you as well. Okay. If you dig into the patient's history and you find out that they've got some neurological conditions or developmental history issues, right, as we see here, cerebral palsy, muscular dystrophy, etc., then that may be an indication for referral. Questions or comments? So, throughout this last block, right, we talked about splanus, we talked about toe walking, tarsal coalition, osteochondral lesions of the talus, metatarsus abductus, adductus. What are your questions on this? None? All right. Okay. I want you to take 5 minutes in place. We're going to talk about fractures, right? I want you to shift your mind. We talked about all these different conditions a few minutes ago. Now we're going to talk about some trauma to cover in these next few blocks, right? So if I am going too fast for you, I want you to raise your hand and ask me to slow down. Otherwise, I'm going to assume that you are just soaking it all in and you're doing well, okay? It's an opportunity for you to have a little bit of say in how these next few blocks go. Okay? Entirely up to you. We'll make a huge assumption that between your anatomy and what metabolos taught you, that you retain a whole lot of it and you did not dump it all before your cardio exam this morning. So, let's see. Okay. So we're going to review subluxations and dislocations. What denotes a sprain versus a partial dislocation versus a complete dislocation. We're going to talk about how you describe fractures. Okay. We spent a little bit of time on fractures of the growth plate. Not a whole lot, because I know you got some of it in your previous blocks, and I was told that you covered it at length during your radiology blocks. Is that true? I see some people say no, and some people are, right? If you forget all the discussions you had on Salter House fractures. Rings a bell? All right. we go. We'll talk about some fractures of the C-spine, fractures of the T-spine, fractures of the lumbar spine, okay? And then we'll get into some extremity fractures. Now, how do you recognize what's a fracture, what's a dislocation, what is a subluxation? Are these terms synonymous with each other, right? And how do you tell one from the other, right? So, a dislocation is anything that shows that the congruency of the joint is offset, okay? It's a loss of congruency of the joint surface. It may be complete or it may be partial. If it's partial, then it is considered what? Subluxation, right? So a complete dislocation, as you can see in the picture on the right side with the red box, you've got a complete disarticulation of that joint surface, right? Since we're talking about the knee, and yes, that is the knee that you're looking at, hopefully you recognize that, okay? That little bone you see in the front is what? Okay, check on the money, just making sure, right? What structures are at risk in a dislocation like this? Yeah, puppeteer, what did you say? It depends. They're giving me the higher level army school answer here. It depends. Depends on what? Okay, that's a good point. Is this thing considered a posterior dislocation or an anterior dislocation? Anterior dislocation, why? Because it's based on the distal fragment. I should just stop teaching right now and send everybody home. Good try. Okay, so it's all based on the description is all based on the distal fragment. Okay? So a subluxation is something that we would call a partial dislocation, right? We established that. And when it's more complete, then we've got a full dislocation. In the case of this hand that you see on the left diagram, sometimes you cannot tell if there is a partial subluxation, right? And in this case, you may have to rely on your expertise in reading radiographs, or you listen, or you look at your radiologist report, okay? Can anyone see which bones on the left diagram with the green box looks a little bit abnormal? See a couple of people wiggling their thumbs. Okay, assuming that it is the thumb, then what's the problem with the thumb? So first you have to know what looks normal, right? And in cases, and normal is relatively, right? And in cases when the thing looks normal, then you have to ask yourself, do you have a correct radiograph? Remember I told you that your radiographic techs will do their best to get you the right views, especially the ones that you ask for, right? You could argue that there is a little bit of incongruency at the thumb MCP. Is that correct?
Yeah.
Right? Right here. Okay. It's a little more pronounced in the picture on the right side. And so when you describe these dislocations, remember that you always describe the dislocation in relation to the distal fragment. You describe the subluxation of the joint in relation to the distal fragment as well, right? But that subluxation is always referred to as a subluxation at the joint surface, right? And they name the joint. Each. Okay, let's talk into some basics of fractures, right? We're going to name some fracture fragments. We're going to take a look at how the fracture line allows you to describe the fractures. Look at the fragments in relation to one another. And then finally we'll talk about the relationship of the fragment in space and time as opposed to whether or not it's open or closed, right? So, first you have to understand which bone is broken. This is where your anatomy comes into place, right? Remember I told you at the beginning of class, you have got to know your anatomy. Because when you describe these things, even to your patients, even if you break it down and speak to them like they're 2 years old, but it's helpful for them to have the confidence that you know what you're talking about. If you're humming and hawing, trying to figure out exactly which bone is broken, that's a problem, right? Lose confidence of the patient. When you speak to your peers and certainly to your specialty team, you've got to be able to talk medical terminology, right? And yes, we do call it clavicle collarbone. But if I'm speaking to a specialist describing a fracture, I'm going to tell him that the patient fractured his collarbone, right? That's how you speak to your patients, right, when they have no idea what you're talking about. And then we have, since we know, right, since we know the different parts of the bone, we know the epiphysis, we know the diaphysis, we know the proximal versus the distal part of the bone, we know the shaft of the bone, right? Then we describe those fractures in relation to those parts as well, okay? Now, we're not going to go into different classifications, and I'll tell you that there are tons of classifications out there. Okay? Classifications are not as important as we think they are. They're helpful in academia because, you know, it makes us sound smart. But in the grand scheme of treatment, outside of if you are in a specialty clinic, classification is not as important. However, there are some that we will want you to know, right? Like the Salter-Harris classification, because it's widely known that that classification is solid, and vast majority of us know and understand what it means and what it is. Okay, let's talk about different fragments of bone, right? See, if a bone is broken, first of all, what is a fracture? How would you define a fracture? A fracture is a disruption of the cortical integrity of a bone. Just means that the cortex in some way, shape, or form is compromised, yes? Okay, so if you're looking around and you see, and you're looking at an x-ray, right? You're looking at an x-ray and you notice that the cortex does not look right, but there is no fracture line in said cortex. Doesn't mean that it is fractured. What do you think? That's this. Possibly, right? But maybe not, right? What would be your next correlation? Compare it to the other side, right? And certainly, if you have a patient in front of you, then you compare that to your physical exam. Hopefully you get that first, right? Okay, so in the diagram on the left side, there are two fragments to the bone. Two fragments of the radius of the ulna, right? Now, question for you. In that left-sided picture, which bone is fractured? Is it the radius or the ulna?
Radius.
Because it says it in the picture. How do you know it's the radius? Because it's on the thumb side, right? This is where you got to know your anatomy. Okay. On your right picture, you'll see that that fracture is in different segments. Yes? So you've got a simple fracture, which is a break in one section of the bone. You've got a comminuted fracture, which means that there are multiple fragments. Okay? If you have whole segments of a bone, if you have entire segments of a bone, even if it's broken in multiple places, that can be considered a segmental fracture. Yes? Because you have whole portions of the bone broken. And a way that you tell, we'll see that on the next slide, a way that you tell is that a segment of bone is bordered by a fracture line on each side, right? Comminution just means that you have lots of pieces of bone. And so if you look at the right picture, right, that says many, you've got a segment of bone, but you also have some other small pieces of bone at that fracture site as well. You guys see that? That is a comminuted fracture. It is still a segmental fracture because you've got a segment of bone, right? Full segments of bone with a bunch of additional small pieces. You may have heard about the butterfly fragment, right? That's this little thing that looks like butterfly wings. Depending on the type of bone, it's important, maybe not important. Sometimes butterfly fragments have, depending on where they are, they might have some other attachments, right? Muscular attachments or tendinous attachment to them. But in the case of most of the long bones, right, if it's a mid-shaft fracture, not that important. Okay. It becomes important to us based on where those fragments are and how we get it, if we have to do some operating management. Questions about this? Right. Okay. Transverse fractures. As the name says it all, right? The transverse fracture is simply a fracture in which the fracture line is perpendicular to the long axis of the bone, right? An oblique fracture is one in which the fracture line is angled to the long axis of the bone. A spiral fracture is one in which the fracture line is angled, right, to the long axis of the bone. However, that fracture line is present on two different views. Okay? That's how you can differentiate a spiral fracture from an oblique fracture, okay, or angulated fracture. So if you see, if you notice something that looks like an oblique fracture and you only have one view, it is almost impossible to tell that it is a spiral fracture or not. And most times you get spiral fractures because of some twisting motion, right? It allows the bone to break in two different planes. Displaced fractures are fractures in which the cortical ends of the bone, right, are separated from each other at the fracture site. Okay. So, in the case of your diagram on the right side, there is some degree of displacement, right? See that? So the fracture ends, right, where they should meet up and separated. If you also notice that there on this picture on the left, right, far right picture on the left, you'll notice that the ends of the bone, right, the bones are actually shortened and the fracture ends are opposed to each other, right? for that bayonet apposition. And all it means is because of the muscular pull on the bones, you got the bone ends overlapping, right? In the case of this clavicle fracture in the left diagram, you see that degree of displacement? You also see that the proximal fragment is oriented superiorly as well, right? And your distal fragment is oriented inferiorly. Are there any complications that can potentially occur with clavicle fractures in which that distal fragment is oriented inferiorly? Say again? Is it hemothorax or pneumothorax? Why? Okay, that's how you would describe it to a non-patient, but since we are in an academic setting, I'm going to ask you to
tip of the mid shaft, they displace clavicle, angle inferiorly, total cavity,
that is a Herculean effort. Not wrong, right? Absolutely not wrong. You're absolutely right. So you've got that displaced fragment. What lives in that portion of the shoulder? The apex of the lungs, right? And so you've got inferior displacement of that distal fragment, right? Puncturing the apex of the lungs, right? And more specifically, can puncture the throat cavity and pneumothorax. We're going to get into clavicle fractures a little more, but what condition, why is it that if you have an apex superior, right, look at that right picture, you got an apex superior orientation of a clavicle fracture, what other problems can they have, especially on our population? Rock bearings, exactly, right? Because of your rucksack straps, right? Sits right in the middle of the clavicle, right? Right across the clavicle. That's what you said, rock bearings?
Yes.
Okay, just making sure, right? Okay. Questions about that? All right, we talked about bayonet apposition, so if you notice here, and my apologies for the overlapping words up here, so disregard that, don't look at it. Talked about bayonet opposition, right, here with the different fracture fragments opposing each other, okay? And you can see the same here. Oops. Right? You see the same in that far right picture as well. Okay. There may be instances when, as in this case, you've got a tip-fit fracture and the lower portion of the fracture, the lower segment of the fracture is rotated, right? You guys can see the rotation, right? Look to the far right picture. Because it looks like you have an AP view of the anterior segment and a lateral view of the distal fragment, right? That's how you know that it's rotated. And if you looked at that foot in real time, right, at the fracture site, the foot and lower leg would probably be looking about perpendicular to each other, right? So your foot would be pointed, right, towards the outside, or towards the inside, because it's all rotated. In the case of that distal radius fracture on the left, there is a lot of comminution and shortening of that fracture, right? Can you see that? Left side. Okay. Now, if the skin is intact over the fracture site, then that's a closed fracture. If the skin is open, then that is an open fracture. Need you to remember this, an open fracture is an orthopedic emergency until proven otherwise. There are cases where you will have an open fracture that is not bleeding. But if there is what looks like an open wound in the proximity of the fracture site, and it does not have to be directly over the fracture site, it is still considered an open fracture. What we do not want you to do in your practice is to go exploring, poking things through the wound to determine if it communicates with the fracture site. Okay? That's something that we do in the operating room. Not definitely not in the clinic. Now, I said that the open wound does not have to be directly over the fracture site for it to be an open fracture. Now, if you've got a tip-fit fracture and he's got a puncture wound over the quadriceps, right, over the thigh, it's not an open fracture. I'm hearing crickets. I promise you it's not a trick question. So if there is no femur fracture, but you have a tip-fit fracture, you've got a wound in the thigh, is that considered an open fracture? You say yes?
I'm not understanding your term.
So I told you two things, right? One, an open fracture is a fracture in which the fracture site communicates with the atmosphere, right? Essentially, there's a break in the skin, and the break in the skin does not have to be directly over the fracture site. So, it stands to reason, right? If you break a bone, the bone pokes through the skin, now you have an open fracture, right? Increased likelihood for infection, okay? But what if the wound, the fracture site is in the leg, right? Tip fin, and the wound is in the thigh. That considered an open fracture. No. Right? Different compartments. What do you say, Major Davos? Open fractures can be increasingly problematic to treat. We had a guy who was doing a parachute jump a few years ago in Houston. Okay. Had a parachute mishap and he burned it, right? Meaning that he fell a little faster than he normally should fall, right? Shattered his right femur. Now, it's true that I think Herman Memorial in Houston over the weekend and brought to us at Bansi a couple of days later. And his report said that they'd taken a significant amount of bones and stuff out of his leg. Right? And when we washed him out, indeed, he still had dirt and grass and everything else. Yeah. We removed the nail that was placed in the leg, washed everything out, and had him on the ward. In fact, the next day took him to the OR, there was more dirt and grass coming out of the wound. And this went on for about a week. And each time we thought we'd done due diligence and taken all that dirt and grass out of the wound. So, am I telling you that in some of these fascial planes, it's unconscionable how much stuff can get into those places. Okay. And so that guy was on the verge of developing some serious infections. Why? Because there was all of this debris, right, in the wound. That's why open fractures, it's very important that you treat them surgically. All right? Be back at 10 after. So, we describe, right, the different relationships of fractures and how they relate to not just the proximal and distal fragments, the orientation of fractures. We talked about whether or not these fractures are open versus closed, right? Remember I told you that open fractures are what?
Break the skin.
Say again? An ortho emergency, right? And you'll realize that in all population, when there are open fractures, they are not necessarily clean injuries either, right? Picture a patient, and you know, we just had a discussion over the break, patient with a gunshot wound that results in a fracture, then you've got all sorts of debris, right, being tracked into that wound. Shrapnel wounds that result in fractures take with them whatever is on the surface of the body and drags it into the wound as well. Not to mention that your casualty may be sitting in a ditch, right, of dirty water, maybe sewage water, for quite a while, okay? So all of these things, you know, lend to the dirty nature of the wounds and why they need to be surgically evaluated, okay? And so once the skin is open, then you know, it's a safe bet that these wounds are potentially contaminated, right? And so antibiotics early is the order of the day, right? Now, fractures of the growth plate. I think you covered that ad nauseum. I think you, if I recall, you probably covered it in your last class as well. You did cover it very, very extensively in radiology. And so we're just going to revise and review a couple of things. Okay? Number one, the Salter-Harris classification is the classification of choice for growth plate fractures. In case you forgot, I do need you to remember this for the rest of this course and certainly as you describe fractures in your practice. Okay? You can see what a normal growth plate looks like and what an injured growth plate looks like. Okay. Remember that as the bones continue to ossify, the growth plate continues to be a source of weakness in the construct of the bone. Okay? Which is why, in the case of growth plate fractures, it's not very difficult for kids to have a growth plate fracture. However, the complications of not treating a growth plate fracture can be pretty significant, right? And why is it called a growth plate? Because that's where the rest of the bone continues to grow. And so therefore, right, if it's injured, means that there may be abnormal growth at that location, at the site of injury. And if you've seen kids with growth plate fractures that remain untreated, it can be pretty significant and debilitating for them. Okay. Type 1 fractures are fractures across the growth plate. Type 2 fractures, right? Type 2 fractures across the growth plate and into the metaphysis of the bone. And you notice that as I describe these fractures, I start with fractures across the growth plate and, right? Because all of the Salter-Harris fractures involve growth plate. Type 3 fractures are fractures across the growth plate and into the epiphysis, right, or the distal part of the bone. Type 4 fractures across the growth plate and both the epiphysis and the diaphysis of the bone, or the metaphysis of the bone, right? Metaphysis and diaphysis. And then, of course, you have the uncommon type 5 fractures, which is really a compression injury across the growth plate. Okay? It's type 5, but it is the most damaging of the Salter-Harris fractures. Type 2 fractures are the most common. Okay? Type 2 fractures are the most common. There's a question for you. Of all the Salter-Harris fractures, right? Of all the Salter-Harris fractures, which ones are intra-articular?
Three and four.
3 and 4, right? You guys see that? Okay. So if 3 and 4 are intra-articular, right? That makes them amenable to what kind of treatment? Operative or non-operative?
Operative.
Operative management, right? Because they are intra-articular. And when we start talking articular fractures or intra-articular fractures, you realize that if you have one of those, then you better have somebody else seeing them besides yourself, right? At a minimum, get a second opinion, or refer them to someone with a little more expertise, okay? Type 5 fractures are also fractures that should be sent for further assessment. Any questions about this? Another point that I'd like to make here is that, and we talked about this earlier, if you're not sure about what you're looking at, right, take a look at the contralateral side. We talk about different studies of choice for various conditions, right? I told you that the MRI is the study of choice for looking at osteochondral lesions, right? Even if it is in the subtalar joint. And now I'm telling you that the CT scan is a study of choice for looking at intra-articular fractures, right? Salter-Harris fractures. So when you see a Salter-Harris fracture, as you see in that Salter-Harris 2, the second diagram from the left, right? It is very easy to articulate that as a fracture of the metaphysis, right? Without taking into account that yes, it extends into the joint and potentially, right, affects the growth plate. The Salter-Harris 3 here, that definitely is intra-articular. Okay. Sometimes some of these fracture lines do not show up on X-ray. Okay. Sometimes they do not show up on X-ray. So you have to understand and have a high index of suspicion to understand how you need to treat these. Okay. The goal of treatment is anatomic reduction, right? And that's the same for most of the fractures we talk about, just to make sure that the bone continues to look like a bone. In the case of Salter-Harris fractures, is to ensure that we do not do something that arrests continued growth at the fracture site, right, at the growth plate. Just like most things that we do in orthopedics, 4 to 6 weeks is a sweet spot, right, before you bring him back for further assessment. Okay? And we just talked about this. Salter-Harris 1 and 2 are amenable to non-operative management, right? Put them in a cast, 7 to 10 days, reassess. You do have to continue to closely follow them. 3 and 4, absolutely, those are intra-articular and need to be looked at by a specialist. Kids tend to heal fairly quickly, right? You may see fractures that can be significantly angulated, right? When you look at it on X-ray, and the remodeling process as a child grows, it's amazing how the bone straightens itself out, right? So if you have like mid-shaft fractures that there's a certain degree of angular tolerance that we'll allow, and still have, it's not much of an issue. Questions about Salter-Harris fractures? Okay. Fractures of the C-spine. Okay. Most times you get fractures of the C-spine in high impact, high energy trauma. In most cases, you will err on the side of caution and stabilize the C-spine, the cervical spine, in the event that a fracture is present, right? That does not show up on your physical exam. In most cases, you won't know. And even after you've done your physical exam, and we'll talk about some things to look for in the physical exam, you still can't tell. So if you have a high energy trauma to a patient, then you want to make sure you protect the cervical spine. Okay? It was a few years ago when we started building some of these spaghetti highways that San Antonio seems to be very fond of. You know, folks like to jump off these overpasses. What it was, it's like a few years, and almost every weekend someone was jumping off an overpass, right? If you live in New York City, how many of us are from New York? Right? I don't know. Something about that Brooklyn Bridge that people seem to be fond of. They look at the water, it looks nice and inviting, and they want to go for a swim. Right? High diving off Brooklyn Bridge. Couldn't understand. Okay? This type of trauma fall from that kind of height is very significant. And water might be soft. When you hit it from at velocity, from a height, it is as hard as concrete. Okay? Very significant injuries. You cannot clear a C-spine, right? And this is going into medicine a little bit, in a patient that is incoherent. So, the patient is drunk, the patient is on medication, right? If the patient is old and has dementia and has a C-spine injury, it is very difficult to clear that C-spine. You cannot do that in your clinic, right? That person has to be in an emergency room or an operating room, okay? So, a way that you can tell if there's a C-spine injury as part of the physical exam is not to look for range of motion of the neck. It's a bad way to go. You only compound the injury. What you do is, during your palpation, if you find that there is a step off or a gap, okay, with or without neurological symptoms, then you should have a high index of suspicion during your exam. If there is a hematoma in the C-spine region, if you've done your C-spine physical exam, you should know where to find C7, right? Okay.
Most prominent.
Most prominent, yes, right? So you would not necessarily call that a hematoma, but if the patient is tender at C7, then, right? So you see, none of these things is black and white, right? And like I told you guys in the beginning, right, there's some things that you did as, you know, nurses, combat medics, PTs, etc. You're way past that now. You're the person that now owns these patients, right? You have to make that final determination, or call somebody that can. Any patient with a spinous injury, whether it's C-spine, T-spine, lumbar spine, you absolutely have to do a neurovascular exam. You should do a neurovascular exam for any patient, but for patients with spinal cord injuries or potential spinal cord injuries, you have to do a neurological exam. Okay? We talk about some of these reflexes, right? Perianal sensation, sphincter tone, the bulbocavernosus reflex. Talk about it briefly when we get into fractures of the lumbar spine. Okay. But you have to make sure you test those reflexes. When we do the labs tomorrow, we'll talk about some of the reflexes in the foot and ankle, right? The Dinster reflex and the Achilles reflex. Okay, let's talk imaging for a second. In modern medicine, like in the old days, we do a series of x-rays, right, to assess the C-spine. Now, every trauma patient in large metropolitan hospitals to get head-to-toe CT scans, right, which gives a better degree of visibility on potential injuries, right, potential fractures. A cross-table lateral allows you to see from the occiput through T1, right? Some of the other special views, like the odontoid view, right? You guys cover this in radiology? Okay, so we're not going to spend a lot of time with it. That's the open mouth view. You've got the swimmer's view for the CT junction, and then flexion extension views, right? The problem with flexion extension views is that if you do those in the absence of clearing the C-spine, right, then you can cause further injury to the patient. So you don't order those, right? Because the radiologist, the tech, is not going to know that you didn't clear the C-spine. That's not their job. That's your job. If you get a patient with radicular symptoms, then of course, right, you want to use an MRI for further assessment. Now, sometimes you may not see a fracture on your x-rays. However, a way that you can tell if a patient has a C-spine injury is if at the level of C3, swelling, soft tissue swelling is greater than 1/3 the width of a C3 vertebral body, right? It's not at C5, it is not at C7, it's for other things, right? Find C3, measure the width of the vertebral body, measure the anterior soft tissue, and if that tissue width is greater than 1/3 the width of C3, right? So 1/3 is normal, greater than 1/3 is abnormal. Questions about that? Does anybody not understand what that means? Okay. So, again, right? C-spine x-rays. Width of C3, greater than 1/3, right? Soft tissue width greater than 1/3, that is abnormal. It means that there is some swelling at that level. Non-operative management immobilization in a C-collar and a spine board, that is standard for the vast majority of trauma patients that you will see. If you're the first one on the scene, then that should be your job, right? Immobilize the patient until you can determine that they do not have a cervical spine injury. Okay? If your neuro exam is normal, if the patient is not otherwise attuned, okay, and if your x-rays are normal, then your degree of suspicion for C-spine injury can decrease. Make sense? You got your radiographic films, you got your physical exam, and then you got your mechanism of injury. Okay? If you find there's an unstable pattern, right, i.e., soft tissue greater than 1/3 the width of C3, or you've got some crepitus on your physical exam, or patient continues to complain of pain, or there is ridiculous symptoms during your physical exam, that's an unstable fracture pattern, and they should be referred to someone else. Questions, comments? Fractures of the lumbar spine. Okay? Again, high energy trauma fall from heights. So, in any one of these, and the same goes for C-spine fractures as well, right? There can be subluxation of one vertebra on another, right? Lateral translation, either way you want to put it. The fracture lines, the spinous lines are no longer aligned vertically. Okay? So if you have torn ligaments, or you have anterior-posterior translation of one vertebrae or vertebra on another, then that's an unstable fracture pattern. You normally should not have lumbar spine fractures in the absence of trauma, right? And if you see those, then you have to be concerned that there was something else going on, right? And so if a patient is not in a motor vehicle accident or fall from height, or simply patients are walking, doing their normal daily activities, show up in your clinic with potential back pain or radicular symptoms, and suddenly they have a fracture of the lumbar spine, then you should be looking out for some other pathologic conditions, right? Osteoporosis, cancer, infections, etc. Compression fractures, I think we talked about this in another lecture, is, as the name suggests, right, a shortening of the anterior aspect of the vertebrae. If you do not treat these things, then of course their instability persists. They can lead to deformity because spinous nerves and the spinal cord lives in the vicinity of these fractures. Okay. Now, we talked about in the neck, you know, part of your physical exam. What do you do for the trunk and certainly in the lower back? Okay. You also have to look out for swelling, look for ecchymosis, right? That goes for any orthopedic condition. Okay. Gaps and step-offs, and then of course your neurological exams. Okay. You guys went over deep tendon reflexes, right? Okay, and we talk about a few in the next class. Did you talk about the anticlonus and the Babinski reflex? Should have done those in clean skill, right? Perianal sensation. If you've got a lumbar spine fracture, you've got porta equina syndrome. Does it ring a bell? Right? You have loss of sensation in the saddle area, right? If you were sitting on a saddle, or on a motorcycle, or on a bicycle, that area of your body that comes into contact with the seat, that's why it's called the saddle area, okay? If you have loss of sensation in that region, in the presence of back pain or back injury, then that raises your index of suspicion, okay? Several years ago, we were getting ready to do a rail operation, so we were lowering tanks at a railhead and taking them someplace. Okay. So they jumped off a tank, reached down, grabbed one of these mega wrenches that we use for ratcheting the thing down, and right there, peed himself, laid down, unable to move, just like that. Okay. Just like that. Slip to this, shearing forces, impinge his lumbar spine, instant porta equina syndrome, sent him to the ER because of surgery that day. Organ. And if I recall, I think he was like in his early 20s. Shaped the rest of his life. On the question of what do we do when we have these things, right? You know, Yeah, everyone, surgery is great, right? Here's a little, am I being recorded for this? Okay. Now you're fine. Okay, surgery is great. Back surgery, absolutely phenomenal, right? Half the people that get it, they will award the Nobel Peace Prize to the person that invented it. And the other half wants to shoot that guy. Okay, right? Because there's a small subset that do very well with it. But when you don't, it's debilitating. And so when you go, if you have some chronic back pain, right? And certainly if you live past 50, it's terrible, right? And it will be offered to you based on the things that you do. How many airborne folks you got in? Okay, right? The more you jump, the more likely you want to break something, right? But we got people that do well, right, with these high impact operations. Shouldn't stop from going to airborne schools. If you want to go, by all means, go ahead, okay? But if you continue to injure your spine, right, and you end up having to have surgery, pain should be a limiting factor, right? Because if you can tolerate it, then I would say tolerate it. The risk is, we're not there yet, right? Am I crazy? We're not there yet where your spine surgery is so great that 80–90% of the folks love it. Right? Just a tip. Don't say I said it. Delete that from the video. Okay. Checking for sphincter tone. So in patients, if you touch the anal sphincter, they should contract, right? Should. Okay. You should have some, so that's called the anal wing. Sphincter tone, right? If you insert a gloved finger, emphasis on a gloved finger, not treat these patients, you don't have gloves. Okay? Insert a gloved finger into the anal sphincter, right? There should be some tone. Should. Okay? The absence of anal tone or sphincter tone doesn't mean that they have a problem like this. But generally speaking, they should have sphincter tone. We talked about the BC reflex, the bulbocavernosus reflex, right? We bring that up in the next slide. But if the patient has a Foley in, or if you tug on the glans penis or stimulate the glans penis, then you should see some sphincter contraction. Okay. All right. Plain films, AP and lateral of the lumbar spine. You should never do lumbar spine films with only one view. You should not do any ortho films with only one view anyway, right? If you got a burst fracture, then certainly you will see that compression. Okay. CT, of course, is the modality of choice for looking at these fractures when your x-rays are either inconclusive or you need additional fidelity. Okay. Right now, we've come a long way, and we have actual 3D reconstructions where we'll take a film, get a CT scan, and then they do a 3D reconstruction of the film. I think I have a picture in coming up again. How do you treat these? Well, number one, it all depends. Okay? In the case of lumbar spine fractures, you can put them in a lumbar brace. Okay? If the compression fracture is less than 20 degrees of wedging, as we saw in this picture, right? Look at the far right, bottom right. Okay. If it's less than 20 degrees, then they're amenable to non-operative management. Okay. And that brace will stay on for 8 to 10 weeks. So, remember that the goal of treatment is to prevent further injury and restoring that normal alignment. Okay? If you have unstable burst fractures or flexion destruction injuries, then certainly they will be amenable to surgical management. Not all patients with spinal injury require surgery. Okay? You don't all require surgery. And so, If you got a patient with a compression fracture that is less than 20 degrees of wedging, they can go in a brace. Now what happens if it's beyond 20 degrees? Then they go to surgery, right? Feel like I needed to say that. Red flags, of course, make sure that they don't have neurodeficits, burst fractures, and fracture dislocations. Okay, let's talk fractures of the extremity. Most of these have a history of trauma, right? Extremity fractures don't just happen. There has to be a force on the bone that is greater than what the bone can sustain, and therefore you've got a disruption of the cortical integrity of the bone. Okay? If the fracture is in a joint, that predisposes the patient to osteoarthritis. Okay? If I ask you, when you're in my clinic, to present a patient with an intra-articular fracture, okay? If you do not treat that fracture, more than likely, it's very likely, that the patient will develop osteoarthritis. Okay? There are some watershed areas in our body. Scaphoid is one of them, right? And watershed in the sense that the vascularity of the bone at that junction is not as great, right? The femoral neck is another one. Fractures about these areas, okay? They're prone to cutting off the blood supply, and the distal portion of that bone may eventually die, right? In the case, let me clarify. In the case of the femoral neck, right? I'm not talking about the shaft of the bone dying, right? Okay. I'm talking about, if you look at how the head of the femur fits into the acetabulum, right? You've got the femoral neck, and so that ball, right? That's the piece that tends to want to die from a lack of vascularity. That condition is called what? Osteonecrosis. Okay? So if I ask you what is a long-term complication of femoral neck fractures or scaphoid fractures, then osteonecrosis is the answer to that. That's why these conditions need to be treated very acutely. Okay. You want to make sure you immobilize extremity fractures, immobilize the joints above and below the fractures, and you always do a neurovascular exam. Okay. I think we beat this horse to death, that in the case of children, or if you're just not sure, take a look at the other side. Okay? Give you a good idea as to what's happening. Some of these do well with just plain films, but in the cases that we discussed that are amenable or open for again an MRI, then a CT is the next study up, right, for determining the extent of the fracture. Fractures that are stable, non-displaced, minimally displaced, right? These you can treat non-operatively. Fractures that are displaced and intra-articular, right? If there is a more than 2 millimeter displacement of a fracture within the joint, okay? Fractures that are open, these all must go to specialists for operative management. Okay? In the case of, is a green stick fracture displaced or non-displaced fracture? Non-displaced fracture, right? So would you send it to ortho, or is it open to operative, non-operative management? Right. Making sure you can read, like this. Okay. Not all fractures heal as well as they should, right? In some cases, even with operative or non-operative management, the bones don't come back together like they should. Okay? And in that case, you've got a non-union. A non-union is a fracture that, despite its the intervention, does not fuse together. There may be some callus buildup at the fracture site, it just does not feel like it should. Okay? Malunion is one that, in which, whether with non-treatment or with treatment, then it does not heal in the orientation that it's supposed to. Right? Whenever we do some of these procedures, right, meaning ortho, depending on where the anatomic location of the fracture, then there is prominence of the hardware, right? So when there is not a whole lot of tissue covering it, right? The clavicle is one area, the ankle is another one, right? We put plates and screws, and then these things are so close to the skin that if you continue to wear on the skin above the hardware, then it just erodes through the skin. Okay? So multiple cases like these. So that hardware prominence becomes an issue for the patient. We've got better ways now of fixing clavicle fractures, but in the old days, you just used to put a plate over it. Don't wear a rucksack for a year, right? You tell that to an infantryman, all you're going to do is put some padding over it and put his rucksack on and carry on. Okay? Comes back a few weeks later with a little hole in the ear, right? But I thought it was hurting. I just figured it was healing because it's painful. No. Okay? Now we have other ways of treating these things. But understand that if he's got a clavicle fracture and it's superiorly angulated, then he can have the same issue. Fractures that occur without, right, without some shearing force or low impact, then you got to start looking at whether or not it's pathologic or not. Okay? What's a good reason for a pathologic fracture? Well, not because she's old. Cancer is one of them, right? Osteoporosis and cancer, right? Okay. What else? Yes. So you've got a weakened bone, or you got a bone that has a tumor in it, right? And yes, you can find them in old people, but not for all old people, right? Have weak bones. Okay. Any questions about these? I know you guys are just ready to go, right? Okay. Tomorrow we will go through a couple of videos, right? I think if you haven't seen them yet, we'll send you just a list of things you're going to do during the exam. We talk about an ankle exam.